Hello everyone. In this lecture, we are going to start the complement system. Complement system is actually it's a very important pathway, very important system that plays a major role in host defense. It is actually a component of both innate and acquired immunity. The complement system is comprises of around more than 20 proteins, and these proteins are made from the liver. Now, what happens in this system? We have various proteins, and all these proteins have protease activity. Okay, so all these proteins have protease activity. So once one protein is activated, it can cause activation of another protein. Actually, it can cause proteolytic cleavage and activation of another protein. Like this, there will be sequential activation of various complement proteins, and ultimately they will cause the tissue damage. Okay, for example, if they come in contact with a microbe, there will be activation of one complement protein, and that complement protein can cause proteolytic cleavage and activation of another complement protein. And like this, there will be sequential activation of multiple complement proteins, and ultimately they will cause damage to this microbe. This is what happens in the complement system. Now, there are three pathways for this in this system. One is the classical pathway, then the alternative pathway, then the lectin pathway. We'll start now with the classical pathway, and once you understand the classical pathway, rest of the things are easy. Now, what happens in classical pathway? We'll start with the microbe. So this is a microbe. Okay, this is a microbe, and this is expressing some antigen over the surface. This antigen can be recognized by antibodies which are present in our body, especially the IgM class of antibody. They have highest probability of activating the complements. Following IgM antibodies, some similar, sometimes IgG antibodies can also cause complement activation. Among the IgG antibodies, the G1 and G3 are important. And G4, it never activates the complement. This never activates complement. Other antibodies like IgA and IgD, they rarely play a role in complement activation. Now what happens? Now, okay. So now the microbe, now the antibody is attached to the microbe. Now this antibody can be recognized by the first complement protein, that is C1. Now, as you can see here, the C1 complement protein, it has three components. Okay, one is C1q, C1r, and C1s. C1q identifies the antibody which is attached to the microbe. Once the C1q is attached to the antibody, it will cause cleavage of this C1r. The C1r will be cleaved. Once this is cleaved, now C1s will be activated. It will cause activation of C1s. Now, this C1s, once it is activated, it will cause activation of another complement protein, that is C4. Actually, it will cause proteolytic cleavage. It will cause proteolytic cleavage. By this process, it can convert the C4 into C4a and C4b. And C4b is the active component in this complement pathway. Okay, so now C4a and C4b is produced. Among this, the C4b is the active component. Now, this C4b can actually then cause activation of the C2. Okay, first C1, that will cause activation of C4, leading to formation of C4b. Then C4b will attack C2, leading to formation of C2b, which is the active component. Okay, so C2b is the active component. So I hope it is clear. As you can see, that there is sequential cleavage and activation of various complement proteins. Okay, so now C4b and C2b is produced. Now this C4b and C2b, this combination, which is found in classical pathway, this is known as C3 convertage. C3 convertage. Now, this C3 convertage can actually cleave the C3 protein. It will cleave the C3 protein. Now we'll also discuss the alternative pathway. We'll also discuss the lectin pathway. In all these pathways, the only common thing, the most important common factor is activation of the C3. Okay, so somehow they'll make the C3 convertase and they will activate the C3. Okay, so C3 is the central molecule, the central protein in this whole complement pathway. And also, this is the most abundant. The most abundant complement protein. This is the most abundant complement protein. Okay, so now C3 convertase has attacked the C3 protein. Now C3 again, it will again be proteolized into C3b and C3a. Again, C3b will further I mean, it is the active form and it will cause various, I mean, it will proceed with the next steps. Now what will happen? Now the C3B can be combined with the C3 convertage. As we have already discussed, C3 convertage is the C4B and C2B, as you can see here. So C3B can combine with C4B and C2B, and now they will make C5 convertage. So as you can see here, so C5 convertage, it is made up of C4B, C2B, and C3B. So this combination is actually the C5 convertage. Now this is C5 convertage. Again, it will cleave and activate the C5. It will cleave and activate the C5. Now C5 will again be divided into C5A and C5B. The C5B actually can go and attach to the surface of the microbe. So this is the initial microbe upon which everything is happening. Now the C5B, once it is produced, it can go and it can bind. It can go and it will bind to the microbial surface. It will bind to the microbial surface. Once it is bound to the microbial surface, it will cause activation of further complement proteins. So those complement proteins are C6 to C9. So C5B will cause activation of C6, C7, C8, and C9. Okay. Now this entire complex, the C5B to C9, this entire complex is known as the membrane attack complex. Membrane attack complex. And what this membrane attack complex is going to do? Now this, as you can see here, if this is a membrane attack complex, this will make a pore. This will make pores on the surface of the microbial surface, and that will allow the potassium. Will allow the potassium and water to come from outside of the cell to inner side. Now, as this potassium and water will come inside, it will cause lysis of the microbe. It will cause damage to the microbe. Okay. So in this process, they can actually kill the microbe. They can actually kill the microbe. Okay. Now this membrane attack complex can efficiently kill those bacteria who have a very thin cell wall. Okay. So they can actually, this membrane attack complex can actually cause very severe damage to those bacteria who have a very thin cell wall. And example is Neisseria. So that is why if the patient has terminal complement deficiency, that means if there is a defect in the membrane attack complex formation, those patients are at increased risk of Neisseria meningitis. Okay. So that they are at increased risk of Neisseria meningitis. Okay. So I hope it is clear. So this is all about the classical pathway. I will repeat it again. So you start with a microbe which is presenting, have some antigens over its surface, which can be recognized by the antibody. So antibody can be IgM, most likely it is IgM, and sometimes it is IgG1 or IgG3, and that will cause the first complement protein, the C1, will attach to this antibody, and that will cause activation of the C1, leading to formation of the C1s, which is the active form of the C1 protein. Now this C1s will cause cleavage of the C4 and make the active component, that is C4b. C4b will attack C2, make the active form, that is C2b. Now C4b and C2b, they will make the C3 convertage. They will attack C3 and formation of C3b and C3a. Now C3b is the active form. Now C3b will combine with the C3 convertage, that is C4b and C2b. Now they will make the C5 convertage, that is C4b, C2b, and C3b. Now this C5 convertage attack the C5 and they produce C5A and C5b. Now C5b will go and bind to the microbial surface, and it will cause further complement activation from C6 to C9. And the entire C5 to C5b to C9, this entire complex is known as the membrane attack complex, which will activate certain ion channels, leading to influx of potassium, water, and that will ultimately cause swelling of the microbe and the destruction of the microbe. And this membrane attack complex can actually helps in destruction of those bacteria which are very thin cell wall, especially Neisseria, and deficiency of membrane attack complex can cause severe Neisseria infection. Now, in this pathway, there are various other. I mean, we did not discuss about C4A, C3A, C5A. We'll discuss that later. I mean, they also have certain other properties. I mean, they have certain other roles. Okay, so we'll discuss that later. For the timing, you remember, this is the pathway. This is the classical complement pathway. And also, we'll discuss some of the regulators of this pathway. Again, I will not discuss them here because it will make this slide very clumsy. We'll discuss that later. Okay, so once you understood the classical pathway, now alternative pathway and the lectin pathways are very easy. Let's start with alternative pathway. So alternative pathway is activated either because of some endotoxins which are usually present on the lipopolysaccharide. Usually this gram-negative bacteria, they will have this lipopolysaccharide and which will act as the endotoxins. Sometimes some cobra venom and sometimes some complex polysaccharides. All these things can actually directly activate C3, directly activate the C3. Once C3 is activated, it will make C3b and C3a, C3b and C3a. This C3b will be helped by factor B, factor D, and properdin. So these are the three important factors which will help C3b, which will help C3b. And in this process, the B will be converted to BB, the active form of B. Okay, so in this process, the B will be converted to capital B, small b. Now this C3b along with this BB can form this C3 convertage. C3 convertage. Okay, it might sound somewhat confusing, but this is how this alternative pathway works. So initially, some endotoxins or cobra venom or some complex polysaccharides, they will activate the C3. That will make C3b. Then it will be held by factor B, factor D, and properdin. This factor B will be converted to BB. Now C3b along with BB, they will make the C3 convertage. Okay, and I have already told you that cornerstone of all these pathways is the C3 convertage. Once C3 convertage is formed, once the C3 convertage is formed, rest of the pathway is same as the classical pathway. So I'm not going to discuss them again. So C3 convertage, then they'll make the C5 convertage, then there will be activation of the other terminal complement pathway, then they'll form the membrane attack complex and lysis of the bacteria or the related things. Okay, so this is how this alternative complement pathway acts. And this properdin is also important because this is the stabilizing factor. They will stabilize the alternate complement pathway. They will stabilize the alternative complement pathway. Okay, we'll discuss about properdin when we'll discuss about the renal pathology. Okay, again, they have some regulatory proteins. We'll discuss them later. Now, let us come to the last pathway, that is the lectin pathway. Lectin pathway is very simple. Some of the microbes will have this mannose residues on their surface. These are the mannose residues, and this can be recognized by the lectins. Once the lectins, they recognize the mannose residues over the microbial surface, they can cause activation of the C1, and the further pathway is similar to what we have discussed for the classical pathway. Okay, so this is about the lectin pathway. Now we have discussed about all the pathways, the C3, I mean the classical pathway, the alternative pathway, the lectin pathway. Okay, now we'll see. Now we have not discussed about some of the intermediates that are produced during this process. Now we'll see what are those intermediates and what are their functions. Now this C5a, C3a, and C4a, they are actually anaphylotoxins. They are anaphylotoxins. As we'll discuss in type 1 hypersensitivity. Actually, the type 1 hypersensitivity reaction is that is the major pathogenic mechanism for this anaphylaxis. And in this process, actually, what happens? There is activation of the histamines. Okay, activation of the production of histamines from the mast cells. Okay, from the mast cells. So mast cells will produce these histamines, and that will cause all the clinical features of anaphylaxis. Those things we'll discuss later. So what these things will do? These will actually cause production of histamine from the mast cells. So histamine production from the mast cells, and that will help in the allergic reaction. So these are the anaphylotoxins. Apart from this C5a has certain various other functions. So C5a actually can act as chemoattractant, can act as a chemotactic agent, That means it can recruit the white blood cells into the site of inflammation. Also, it helps in the lipooxygenase pathway. So as we'll study about the arachidonic acid metabolites, pathway metabolites, this lipooxygenase pathway will produce various leukotrienes, prostaglandins and leukotrienes, and all those things also help in the process of inflammation. Those are also the mediators of inflammation. So C5a along with the anaphylotoxin property, along with that, it also has the chemotactic property, and also it activates the lipooxygenase pathway. C3b, this has, we have discussed about C3b, this plays a major role in forming the C5 convertase, but apart from that, C3b also acts as opsonins. This also acts as opsonins. So opsonins basically, they can bind over the surface of microbes and macrophages, they have receptor for this C3b. So they have certain receptors which can actually recognize this C3b, and they can cause phagocytosis and destruction of the microbes. So basically, opsonin means the C3b will make the microbial surface more palatable for the macrophages. So that is about the opsonins. So C3b can act as opsonins also. They helps in the process of opsonization. Similarly, we also have another protein, that is C1q. C1q helps in the process of apoptosis. Helps in the process of apoptosis. This you must have studied when we have studied about the cell injury and apoptosis chapter. So C1q helps in the apoptosis. So these are all the important functions, all the other important functions of the complement proteins. Okay. So C5a, C3a, C4a, all of them are anaphylatoxins. They can increase the production of histamine from the mast cells. C5a, along with this property, it is also chemotactic, and it will also activate the lipoxygenase pathway. C3b act as opsonin, and they helps in the process of opsonization. And C1q help in the process of apoptosis. Okay. Now that we have discussed all the pathways and the functions of these proteins, now we'll see some of the regulators of complement pathway. Now we have a regulator for the classical pathway, that is known as the C1 inhibitor. C1 inhibitor. This C1 inhibitor can inhibit the C1. Then we have another protein which can inhibit the alternative pathway, that is complement factor H. Complement factor H. So complement factor H can inhibit the alternative pathway. Okay, especially the C3 convertase of alternative pathway. Okay. Now you have certain regulators which can inhibit the common pathways, like decay accelerating factor, which is otherwise known as the CD55, and membrane attack complex. And we have membrane inhibitor of reactive lysis, otherwise known as the CD59. This decay accelerating factor, or CD55, they can inhibit C3 convertase and C5 convertase both. And this membrane inhibitor of reactive lysis, otherwise known as the CD59, this can inhibit the membrane attack complex. Membrane attack complex is the C5b2 C5b2 C9. Okay, so I hope it is clear now. C1 inhibitor inhibit the C1. Complement factor H inhibit the alternative pathway C3 convertase. Decay accelerating factor, or CD55, they will inhibit the C3 convertase and C5 convertase. CD59, or membrane inhibitor of reactive lysis, can inhibit the C5b2 C9, that is the membrane attack complex. You need to understand that CD50, this decay accelerating factor and this membrane inhibitor of reactive lysis, these are actually GPI anchor proteins. So if you see a cell, this is the cell. It will have a GPI protein. So this is a GPI protein. GPI protein is glucosyl phosphatidyl inositol. Okay, this is a GPI protein, glucosyl phosphatidyl inositol. And this decay accelerating factor and membrane inhibitor of reactive lysis, they are found attached to this GPI protein. So these are also known as the GPI anchored proteins. Now this arrangement is usually found in hematopoietic stem cells and also in all the hematopoietic cells. Okay. So this concept is important to remember, because when we'll discuss about the paroxysmal nocturnal hemoglobinuria, again this point will come. Now we'll see how you test for the complement system. Now there is a test called CH50. CH50, in this test we can actually do the total hemolytic complement assay. We can do the total complement assay. Now there are three scenarios possible: decrease in C3 and C4 and normal factor B. This is possible if there is a defect in the, if there is activation of the classical complement pathway, C3 and C4, they are involved in the classical pathway. So if classical pathway is activated, C3 and C4 will reduce. But alternative pathway is not affected, so factor B will be normal. But if you see the second scenario, here factor B and C3 both are reduced, but C4 is normal. C4 comes only in the classical pathway, and C3 and B both comes in the alternative pathway. C3 is the common for both. it is, we have to see for the B and C4. If B is reduced, C4 is normal. That means here there is activation of the alternative pathway. Now, if everything is reduced, C3, C4, and B, so that means activation of both alternative and the complement pathway. Okay. So now that we have understood everything, now we'll see some of the diseases that are related to this complement system. First, we'll start with the C1 INH, C1 inhibitor deficiency. Now, C1 inhibitor deficiency will cause a condition that is known as hereditary angioedema. It's an autosomal dominant condition. That means most of the times you are going to get a positive family history. Okay. Now, how it is causing angioedema, that we'll understand by this kallikrein pathway. Okay. So what happens whenever there is this is actually a blood vessel. Whenever there is endothelial injury, this will activate the factor 12. We'll discuss this more when we'll discuss about the coagulation pathway also. That this factor 12 is the initial factor that will get activated in the intrinsic pathway of the coagulation system. Whenever there is endothelial injury, it will cause activation of this factor 12. Factor 12 is otherwise known as the Hegman factor. Okay, this is the Hegman factor. Now whenever this factor 12 is activated, this can produce some of the fragments. It will produce some of the fragments that is known as the Hegman factor fragment. This Hegman factor fragment can actually activate the classical pathway. It can actually activate the classical pathway. Now, what this C1 inhibitor is going to do? C1 inhibitor can actually block this Hegman factor fragment. It can actually block this. In this process, they can actually inhibit the classical complement pathway. Okay. So I have told you previously that C1 inhibitor, it will inhibit the classical complement pathway. Now, this is the mechanism. Actually, the Hegman factor fragment, it can activate the classical pathway. And this C1 inhibitors, they will inhibit, it will come and inhibit this Hegman factor fragment. And this is how it can inhibit the activation of the classical pathway. Then we'll see, then what happens here. Now, this activated factor 12 can actually convert pre-kallikrein to kallikrein. Yes. Now, this can also be inhibited. This can also be inhibited by the C1 inhibitor. Okay. Now, what happens? Now, if the kallikrein is activated, it will convert the high molecular weight kininogen to bradykinin. So, B is bradykinin. Okay. Now, what this bradykinin is going to do? Bradykinin can act upon certain receptors which are present on the endothelial surface. Endothelial cells. These receptors are known as the B2 receptors. And bradykinin, by acting upon these receptors, it can increase the vascular permeability. And subsequently, it can cause edema. It will increase the vascular permeability, release of fluid from the intravascular space to extravascular space, and that will cause edema. Okay, so this is what normally happens. And we have seen that C1 inhibitor can inhibit the Hegman factor fragment, and also it inhibits the factor 12A, which is helping the conversion of pre-kallikrein to kallikrein. Now, this C1 inhibitor can also inhibit the kallikrein. As we discussed, kallikrein will convert high molecular weight kininogen to bradykinin. Now, this process also can be inhibited by the C1 inhibitor. Okay, so C1 inhibitor is acting as a check in all these pathways. Now, can you tell me what is going to happen if C1 inhibitor is not present? If C1 inhibitor is not there, there will be activation of the classical pathway. So that is one part. But there will be severe activation of this bradykinin, severe activation of this kallikrein pathway, which will cause excessive production of bradykinin. And excessive production of bradykinin will increase the vascular permeability. That will cause edema. Okay, that will cause edema, and that is why this condition is known as hereditary angioedema. Okay, so I hope this concept is clear. Now, what are the clinical features? Now, these patients will have episodic angioedema. Usually, these are self-limited. At around by around 48 hours, these are self-limited, but they will cause this episodic angioedema. This angioedema can involve the face. As you can see here, there is severe angioedema. It will produce non-pitting type of angioedema. They can involve the face. They can involve the extremities. They can involve the upper respiratory tract. It is very important to remember that if they involve the larynx, if they cause laryngeal edema, it's actually a life-threatening situation. It is life-threatening situation because laryngeal edema can cause acute stridor, and it can lead to death if you do not intervene immediately. It can also involve the gastrointestinal tract. The edema can happen in the gastrointestinal wall. and that can cause abdominal pain, vomiting, and diarrhea. So these are the various things that are going to happen. So these are all these are all episodic events, and usually self-limited in 48 hours. But if there is laryngeal edema, it can be life-threatening. One more important point to note that these are not associated with any allergy. As you must have studied that there are many allergic conditions which can also cause angioedema. Okay, so those are allergic angioedemas. That is different from this condition because this condition is not associated with allergic manifestations. These are not due to type 1 hypersensitivity reactions. This is only due to excessive bradykinin production. So that is why you will not have urticaria. So in the exam, if they want to ask you about hereditary angioedema, they will give this history of angioedema without urticaria. So that is the clue to diagnose that this is hereditary angioedema. How you are going to treat this condition? You can give plasma-derived C1 inhibitor concentrates. You can also give recombinant C1 inhibitors. You can give kallikrein inhibitors. As you can see here, kallikrein is actually converting high molecular weight kininogen to bradykinin. So if you give kallikrein inhibitors, you can treat this condition. If you give bradykinin blockers, I mean, if you give some drugs which can block these receptors, that is also helpful. Okay, so this kallikrein inhibitors, these are actually icatibant. Sorry, ecallantide. Okay. So as we are discussing the treatment for this condition, we can give plasma-derived C1 inhibitor concentrates. We can give recombinant concentrates. We can give kallikrein inhibitor, and example is ecallantide. We can also give some bradykinin receptor blockers, and example is icatibant. Okay, so these are some of the drugs that are useful. If you don't have anything, at least you can provide plasma. Okay, so this is about the hereditary angioedema. Now we'll see some other pathologies. Now, if there is defect in the initial complement pathways, especially the C1q and C2, especially if there is defect in C1q and C2, it is associated with systemic lupus erythematosus. As we will discuss this more on the chapter of immunology, systemic lupus erythematosus is a condition where there will be formation of autoantibodies. Now, we'll also discuss there that C1q, as I told, they helps in the process of apoptosis. So if C1q is deficient, there will be the apoptosis cannot happen. Okay, so apoptosis cannot happen. So some of the apoptosis of nuclear materials, abnormal nuclear materials cannot happen, and there will be antibody formation to these nuclear elements. Okay, so those are known as the anti-nuclear antibodies, and those are the pathogenic antibodies for this condition, systemic lupus erythematosus. So we'll discuss more on that when we'll discuss about the SLE. So initial complement pathway defects can they play a major role in the SLE. There can be isolated C2 deficiency, and remember, C2 deficiency, complement factor 2 deficiency. This is the most common complement pathway defect. This is the most common complement pathway defect. And this I have already told you. If you have the membrane attack complex defect, there is a risk of severe Neisseria meningitis infection, severe Neisseria infection. Okay, so this we have already discussed. Now there can be some abnormalities related to complement factor H related. As we have already discussed, complement factor H is inhibiting the alternative complement pathway. If there is deficiency in this pathway, it can actually cause a condition that is known as atypical hemolytic uremic syndrome. In this condition, there will be increased complement activation in the glomerulus, in the kidney. We'll discuss more on this when we'll discuss about the renal pathology, or also we'll discuss a little bit about this when we'll discuss about the thrombocytopenias. And they have also found that polymorphism in this complement factor H is also associated with age-related macular degeneration. So this is the condition of vision. This is actually cause of vision loss in older individuals. So polymorphism in this is also associated with age-related macular degeneration. Okay. Now the last one is the PNH, paroxysmal nocturnal hemoglobinuria. This is because of deficiency of GPI anchored proteins, as we have discussed. CD55 or the decay accelerating factor, and the CD59, otherwise known as the membrane inhibitor of reactive lysis. These are the GPA anchor proteins, and defect in this can cause paroxysmal nocturnal hemoglobinuria. This also we'll discuss in detail under the hematology section. Okay, so that's all about the complement system. Thank you.